All right. Hello, everyone. My name is Dr. Arjun Kaur. I'm a consultant psychiatrist here in the ACT. And today we're joined by Dr. Salwa, one of our stage one trainees for our member of the season. Welcome, Dr. Salwa.
Thank you. Thank you for having me.
And welcome to the ACT. I understand you're not from the ACT originally.
No, I'm not from the ACT. I was out west doing rural generalist training before I started here. So I've lived there for a year and mostly been around New South Wales. So that's sort of where I've ended up. Yeah.
Oh,
Thank you.
great. Well, look, welcome to Canberra. I'm Canberra born and bred and very proud of my city. So it's very good to have you with us. And you came from a recommendation from Dr. Ava Carter as our member of the season, because we like to have a broad spectrum of people so that we have some good collegiality within our little territory. So Dr. Salwa, do you mind just telling us a little bit of background about yourself and how you got into medicine, perhaps?
Yeah. Yeah, so Ava did recommend me, but I have to say it's been a bit daunting because I don't know how much I've got to offer, but I'll give it a go. Yeah, so I am sorry. So the question was, how did I come to psychiatry, or what
Well,
was?
maybe you can start with just a bit about yourself and your
A bit
background.
about myself, yeah. So, I'm a stage one trainee. I'm done a bit of GP training before I started, so a bit of rural generalist training out west. Before I started psychiatry, I wanted to be a rural generalist, and actually, there's a lot of overlap with GP and psychiatry, and that's how I've sort of ended up in this role. I mostly wanted to work out bush, and I wanted to work for MSF and all these sort of lofty ideals I had in med school, which I still have a few of with the path I'm currently on, but it's taken a bit of time to get here. So I'm from Singapore originally. I did primary school and high school there, but I'm Indian by background, and I've got two dogs, got two border collie crosses, and I love the outdoors. So Canberra is probably the best place for someone who loves the outdoors. And in my second life, I would have, if I didn't do psychiatry, I'd be a park ranger, which everyone tells me I would not be good at, or I don't know what that means. So it's definitely just an ideal, but I love being outdoors. That's my big thing. So yeah.
Oh, that's really good. No, Canberra is really good for outdoors sort of things. So, and we're very seasonal. So like summer is a proper summer, winter is a proper winter, and we have our
Absolutely.
autumn, which is at the moment, and our spring is really nice too. Yeah.
Yes, it's been beautiful. Being in the Arboretum, like during this time, is just so gorgeous, like seeing all the different colors and yeah, taking the dogs out. I've been really lucky to be here. Yeah.
Absolutely. And Dr. Sawa, did you do medical school in Australia or was that overseas?
Yeah. Yeah, so I did med school in Sydney. I was at UNSW for 6 years. And then I was out regional. I was mostly in Lismore. I was there during the floods. I did like my SRMO year there as a critical care trainee at that time during the Lismore floods. And I was working in ED that day, and it was so that's one of the things that sort of have made me move around a bit. But yeah, that was probably a defining moment in this grand scheme of things as to how I sort of ended up down here. So yeah.
And what way did that end up in psychiatry?
Yeah, so I guess I at that time I knew like I wanted some critical care skills because I knew I was going to be out in the bush, which is what ended up being happening. So I was running a very small ED last year. My boss would sort of be 10 minutes out of town, so I was on call for the local hospital, which had only 3 emergency beds, and you're there for 24 hours, and you manage all this stuff. So that was, and floods happen everywhere, but I met my partner in Lismore. We were intending to stay there for a while, but because of lots of reasons, well, floods is a big reason, we had to leave. His workplace got flooded, and it was a very terrible time. That was probably the biggest man-made human disaster in Australia, one of the biggest ones in Australian history in terms of the impact on human beings. Obviously, the 2019 bushfires have been bigger in terms of the actual environmental impact and the impact on animals and livelihoods, but this was really huge in terms of the actual human impact. Number of houses that got flooded. So yeah, I was working ED. We didn't have any electricity, so everything was on backup. Yeah, we had like dogs lining the corners, like there was people were wet. Like I think we had a couple of arrests. I was pretty junior, so I didn't really do much with those, but it was chaos.
Wow.
So that was my partner grew up in Lismore, so we've sort of made a decision to come down south. So he was here for a year, and then I was out doing GP training for a year. So, and how that sort of came into being in psychiatry was I've always enjoyed mental health. GP is mostly mental health because of the a lot of the motivational interviewing, a lot of the addictions, a lot of pain, a lot of obviously the organic stuff that comes, people coming in for mental health purposes, and then again also the huge nexus between what is a physical symptom, what is a symptom of medically unexplained symptoms, essentially, a lot of that. So that's 70-80% of my job. And I wanted to be able to do more of that in a more in-depth way, because in GP you only have 15 minutes, and that's
we're a bit more privileged in psychiatry that way.
Yeah, we are so lucky to be able to spend an hour with a patient, because that's really all I wanted to do, is that I just felt like it wasn't enough time to address everything that I wanted to address. I still don't feel that way, because it's often we're still quite rushed, but it's still a lot better than the quick, I don't feel the need to get people out the door as soon as possible kind of thing. So that's how I've made my way here. Yeah.
And sort of taking a step back, you kind of said that you wanted to do some sort of work with MSF and, these other organizations. Is that why you joined medicine in the first place?
So it wasn't when I started in high school. So I have to say, in hindsight, I had no idea what this career would bring completely. I think if you're a daughter of two immigrant, brown families, my mum's a doctor, my dad was very poor background, and they basically immigrants, and they work very, very hard. And so that was a big reason for them to encourage me to do medicine. And I'm glad I did it. But it's not what you expect when you're 18, when you start the job. It's completely different. So no, it wasn't. I had to say, I don't think I admittedly thought as much through, because you sort of go based on what your parents tell you. But definitely in med school, I've always been interested in global health, how things affect, mainly poverty and those situations, how they impact people's health. And I've always been interested in that. But I think that's, with psychiatry, we deal with the most marginalized people in society. And I think that's one of the big reasons that I feel that psychiatry has been good in that way, because I feel like we really do, we advocate for those people as much as possible. It's not always possible because of how things work sometimes in the system and how things are, but I think we really do try as much as we can. Not just us, but the whole team. We do what we can. And that's a big thing.
Absolutely.
Yeah.
And how was the transition from Singapore to doing medical school and medical education in Australia?
Yeah. It wasn't too bad. I actually still feel that high school was in some ways harder than medical school. I felt like once I got here, I was like, it's finally time to have a bit of time to relax. Actually, which is very strange. I think it was sort of, you work so hard, and then you finally get in, and then you sort of say, okay, well, I just have to get through the next few years. So I really loved medical school. I absolutely loved it. I had building relationships with friends was the biggest thing. So I really enjoyed those 6 years.
Great. And so you finished medical school, and then you went to Lismore. And what got you into rural generalist rather than psychiatry sort of right away?
So like I said, I was always interested in doing international work, and I still am. I still feel like there's still things that I can offer, and that was a strong thing. So I did a lot of my placement as a student. I did some placements in Alice Springs, and I had this mind of I want to work remote. I want to be able to do that kind of work. I want to be able to do everything, and I guess that GP. I think I still have in my heart, I still feel that there's lots of things about working in a small hospital that I really liked. but there was a lot of things about GP that I really felt that I could do better. And the time was a big one. I think the quality of time that you get with people in psychiatry is in a lot of ways a lot better, because you just get more time and you just get to discuss this one thing. Often it's not just one thing, but they usually come to you for one or two things, instead of trying to juggle 5 or 6 things in a short period of time. So that was the big switch. And of course, personal reasons. I mean, my partner works in Canberra, so he's over here. And long distance, I was like, when I was young and I started, I was like, yeah, sure, we can do 3-4 years long distance. That didn't happen.
Yeah.
So at least now we get to live together. So that's
good, yeah.
Big thing, yeah.
And I guess, so going on from that, perhaps exploring those insights a bit more. Not all of us in psychiatry have too much experience or even knowledge about rural generalists, and I mean GPs to some extent, but rural generalists, especially in ACT, not that much at all. So would you be able to give us a bit of insight into first of all, perhaps how a rural generalist differs from a GP, maybe from mental health side of things in particular?
Yeah, cool. So I guess in general, rural generalism means that you often work at a small hospital. You often have got advanced skill in something. There are lots of GPs now who they're recognising an advanced skill in mental health, and these GPs, particularly in rural areas, may provide psychotherapy. So it's GPs that I've met through my training who've done, like, worked with Black Dog and just do psychotherapy, or do lots of medication management that more than the usual GP might be trained in. And as we know, GPs do so much mental health, often not well remunerated for it, which I feel is one of the tricky things, is that GPs, or at least some GPs, find that it's really hard to manage because you don't get the time. Patients are often complex. So I really feel now, being on the other side, I can understand what it feels like to be a GP managing some of our complex patients. So that perspective has been good. So if I can hand over, I try to. I'm not the best at it, but I do try to do that. If I know they see someone regularly. But so rural generalists, they're trying to do that, particularly in Queensland and other states where there's just such patchy mental health support. And often you are the only person that maybe this impoverished, mentally unwell person sees, and you are the only maybe consistent figure in their life that you see. I remember a lady who I saw every second week for the whole year, and I think just like what I think in psychiatry, obviously unconditional positive regard is important, but so it is so important in GP as well, just being this you can't, there's a lot of moral injury because you can't change people's poverty, you can't change people's circumstances, but if you're just regularly chipping away saying, things will get better, or you say something positive, or you just listen to their ranting or whatever it is, and you're not, you don't take it on, you're not punitive, you're not judgmental, I think that makes a huge difference, really. I think I don't think any of the medicine I did maybe made as much of a difference as just, being someone that people will just be listened to. Yeah.
And so, but by the sounds of things, it sounds like particularly in rural generalists, and if you're in a mental health stream, you're quite supported to do psychiatric care and psychotherapy and those sorts of things.
Yeah. So if you choose it as an advanced skill, which at the moment I don't think New South Wales offers, but Queensland will. Right. There is some supports from that end, and you probably have to do some amount of hospital training to do that. So there is probably more of a structured program, but I definitely hadn't started my advanced skill at that time. But there's so many other psychiatry adjacent things. Like I did so much palliative care. There's lots of people who passed in the local hospital, which was so nice. There's some Aboriginal people who passed, and being able to see them pass on country was really nice. I remember an incident where my boss and I were rounding on this elderly gentleman who had stomach cancer, and he died in her arms. He said, "I need to get out of bed," and we carried him out of bed, and he died on the transfer. And I just think that those were the things that I really remember, is that you see these patients in clinic, you see them in the hospital, and palcare, you know, really going through the spiritual aspects, the emotional, the psychological, that was, I remember that as being really, really nice. If you can do it well, if you can do it locally, if you can do it on country for Aboriginal patients, that was one of the things that made me think about psychiatry as well. And I still might go back and do some more of that in the future. Obviously, I'm stage 1. I still have lots to explore, but I don't know what I'll end up. But healthcare was one of those things that really, you know, if it's such a nice way to, if you can relieve someone's suffering, that physically, mentally, it makes a huge difference.
Yeah, absolutely.
And that's what they say. Oh, sorry, yeah.
No, you go.
Oh no, it's just that you know, any suicidality or psychological distress is, as they say in Palcare, is just a manifestation of inadequate symptom control often. So that's, yeah, one of the things I remember. Sorry to interrupt you.
No, that's okay. You spoke a bit about your interest in global health, and sounds like the social determinants of health as well. I was just wondering, perhaps, you know, now that you've been in Canberra for a small amount of time, and I think you did some of your medical school in urban centres as well. What are the differences between the social determinants in sort of regional populations that might be referred to Canberra psychiatrists, either public or private, versus an urban patient? Is there something you should be aware of as psychiatrists that way?
Yeah, fully. I think, look, there was one of the things I felt when I came here was that we've got so many resources. I don't think the community team where I was working had a service like Heart. I know there's services like Heart in New South Wales in more urban centres, but I don't think any community team from psychiatry was able to visit patients in their own. That's just not possible because of the distances that community team, who was very overloaded and did what they could do based on the resources they had. I mean, I was just amazed that, like, oh, people will come to your homes, like that's a thing, like so that was pretty incredible. So I think it's like, yeah, I think it's just knowing that if you see someone and they're a rural patient, is just knowing that the GP behind them is trying to do their best in what is very limited circumstances. Just getting medication advice sometimes. You know, you don't get paid to be on the phone when you're speaking to a specialist that half an hour. And if you do that for, you know, 10 patients of the 30 that you see, you don't get paid for any of that that time. So it's just, it is hard. I think that if we can make things easier for our GP colleagues, we can. But I mean, in some ways, we're stretched and busy, and we can do what we can here in the inpatient setting. But yeah, that's one of the things is remembering what kind of environments that person's going to go back to, and what does that look like. We definitely did have some tricky patients that we all manage, because we see them and we try to spread some of that mental load in the practice. So we all sort of co-manage some of our complex mental health patients. But yeah, those are the people you see every week. Those are the people you just hold on to, and you give what you can, and then you hope that things get better. But yeah, the complex ones, you just know that GPs are holding on to some of this incredible risk that in the system can hold on to when we work in the city, you know, because you can spread the risk in community teams, you can spread the risk with regular reviews, Heart, all the incredible teams we have. But you just, in rural settings, it's the one GP holding on to this, you know, maybe chronically suicidal patient that they're like, well, you know, I refer them here, they come back, I refer them here, they come back. How do we fix this? And it's just recognizing that some of these patients are incredibly complex and have needs that can be hard to meet in rural settings, for sure.
Okay. I'm going to go on a bit of a different topic now, and that is, so Canberra's also not immune to sort of disasters and disaster psychiatry. We had in 2003 the massive bushfires that we had 3 lives lost, of quite a number of people with severe injuries, and a whole district of ACT burnt to the ground. You know, many homes destroyed and everything like that. And obviously you saw firsthand natural disaster impacting a community in Northern Rivers in New South Wales. How do you feel the sort of natural disasters and how the I suppose climate in which we live in,
Mm,
not necessarily just climate as in climate change, but our physical environment, how
mm.
does that sort of play out in health, particularly in the sort of more acute situations?
Mm, mm. Oh, yeah, that's a really interesting question, and I do think about that a lot. And I think that climate change in general has led to a lot of climate anxiety, and particularly in young people. And I think that that's impacted hugely on their stress levels about, do I even decide to have kids? Will I be able to afford a house? What's the existential threat to our species going to mean for future generations? But even, acutely, like you say, the disaster, we know that Australia is going to suffer, a lot of the areas that are urban and have housing, some of the up to even, I think I don't know if this is correct or not, or I'm putting a number out of something there, but a significant amount of our housing is not going to be livable in the coming years because of disasters.
Hmm.
And, bushfires was huge. That's been a huge thing. And I've had friends who've suffered significantly. My partner, he was impacted by the bushfires as well as the floods, and that for sure impacts people's mental health and well-being. And I think disasters in general, and we know that disaster zones are not good for anyone's mental health. And I'm sure we've seen lots of more PTSD from some of these acute
Mm.
from acute events that have happened globally, of course, with active wars and things like that, but locally as well.
Mm.
In that moment in ED, that day of the floods, I was thinking, what's the fallback? Like, how does a society or a community recover psychologically and otherwise? But there's also lots of moments of strength. I think your community comes together when in moments like that, and I think there was lots of things that doctors had tried, and medical teams, I want to say, had done to try to give back and help from a medical sense. And I think you really see people's resilience come through
Mm.
as well
Mhm,
during those
mhm,
times.
mhm.
But it's hard. I don't know how we're going to manage the future, really.
Well,
But
that kind of
hopefully.
leads me to my next thought, which is, yourself being a young and sort of eager junior psychiatry doctor. Um, what do you feel as someone who perhaps is from a generation where, climate change, climate anxiety
Mm,
are the sort of recipient of without necessarily being,
mm,
well, I guess we all have some sort of shared responsibility. But where do you feel psychiatrists, perhaps as individuals and psychiatry as a body,
mm,
where do we fit in managing or advocating in these sort
mm,
of kind
mm.
of
Yeah.
situations?
Yeah, fully. I think that psychiatrists are probably key in advocating for climate justice, because we know the fallback from it. We know that disasters are terrible for people's mental health.
Mm.
I know that psychiatrists have often spoken up about terrible conditions like the refugee issue. The two psychiatrists who visited um, Nauru and Manus Island have spoken up heaps about self-harm and suicidal behavior in those situations. And I think that the climate crisis is not different. I think that any disaster that will come from it is something that we need to recognize. And like I said, social determinants of health, climate is going to be the determinant of our food security,
Mm.
of our, any trade that goes on, our finances, our housing, all of that's going to play in. And I think that as much as possible, we should, be supporting efforts to do anything we can to reduce harm that's coming from the climate issue. I think any
Mm.
social justice issue is worth talking about from a psychiatric and mental health lens, because it's, well, from a health lens, really, because everything impacts on health. And I think that because we often see the brunt of it, we see the most vulnerable, that we should be speaking up on it as much as we can.
Mm. Mm.
Yeah.
Okay. And I mean, maybe this is asking a bit from you, Dr. Salwa, so feel free to sort of say, I'm not too sure. But being an individual psychiatrist in ACT, or an individual doctor or registrar, how would we make a difference in these sorts of what I would sort of say of really large, really external, very sort of, distant in the future, vague sort of things.
That's
It's not
true,
like
yeah.
something I can patch up, quickly, or I can prescribe.
Mm,
So how does an individual actually make a difference in this environmental
mm,
determinant of health?
I think that if you can strike, you should. I think the kids have been kids. By that I mean they're not kids anymore. But when Greta Thunberg did Fridays for Future, like how does one young person become so incredibly influential, and all that they do is consistently say, "I'm not going to school on Friday. I'm just going to strike. I'm not going to school because our futures are at risk." And Greta Thunberg, who's neurodivergent and amazing, who's made such an incredible impact on how we think and feel about climate. I think if we can do that, I think we should do that. I think I know some people. I have a friend of mine who's incredible, who's trying to do some work with Doctors for the Environment. So they're always looking out for people to do work with. Yeah, I think that the tricky thing though is I don't feel that the climate issue, yes, it affects all of us, but I know that there's a small minority of people who've got a lot more impact on the climate issue, and it's not an individual issue. I think the expectation that's being placed on people individually to ride your bike, which we're lucky in Canberra we probably could, or be a vegetarian, or some of these things that are put down to individual actions or individual things, which are important. We should, if we can, do that. But the onus is definitely on government and big companies who emit more CO2 emissions than the regular working class person. I think is obviously we advocate. I think advocating government to make change is probably the biggest way that we can make changes, because a single company making changes is going to, or a single person making a decision about a large company is going to be more impactful than expecting multiple people who are already in a cost of living crisis, already struggling to make ends meet, to expect that these people are going to be able to follow through with a no waste lifestyle or whatever. Some of these individual things is a lot to expect.
Yeah. Okay. So it seems like a few take homes. One seems like actions are louder than words. So definitely doing something, whether it is policy or advocating or even walking with your feet, is a really effective agency. And also perhaps that we as a college or as an organization should be a bit more powerful as a lobbying
fully, yeah.
as well. Yeah. Okay. Definitely, I think some really good points there. I'm going to now ask a little bit about your personal experience as a stage 1 registrar. I think there's obviously some listeners who are stage 1 registrars and are just new and starting, others who are like myself, who kind of finished but are still sort of early on, and others who might not even recall when they were last a registrar or even met a registrar. So what is it like being a stage 1 registrar?
Yeah.
You don't even have to say ACT. You just, don't worry too much. You won't throw anything under the bus.
Yeah, it's actually been really, really fantastic. I was, people did say to me like, "Oh, I don't know how you're going to go. I don't know how you're going to feel about this, because it's a big transition, starting a new job." And they say, "Oh, you might miss some aspects, physical aspects of the job." But really, I think it's just nice to have a whole team. I've got an intern, I've got a boss, I've got all the allied health staff. Everyone works together. And it's been a lot. In some ways, I found that GP could be a bit isolating. I don't have all these different people, but it's just so nice to actually have people who are all very like-minded, or really care about really vulnerable patients, and not just saying it's, they're a mental health patient, we can't do XYZ or whatever, which can sometimes be tricky, because there's so many other demands that are placed on you that often it's hard to manage in an outpatient setting. So it's been really, really nice, and I just feel that I made the right decision. And I did think
I hope so. Yeah.
Because I did say, you know, I'll keep with the GP college until June, but I've left.
Oh,
Don't
okay, good.
because I said I think I'll I'm gonna finish.
I think as a psychiatry body, I think we're really lucky to have such a fantastic doctor like yourself joining our community. I think we're really that one.
Remains to be seen. We'll hopefully see.
Speaking of training though, and perhaps to give us a bit of insight because you were in an alternative training program, what are some of the differences that you can observe between, you know, starting off as a psychiatry training in Australia versus a different college, which was a college of rural and remote medicine, I suppose.
I was with the College of General Practitioners, but
yeah, sorry, yeah.
you can still do rural generalist training with them.
Yeah.
So yeah, I guess it's been really good to have that year of GP regging down. I just feel so much more comfortable now than I was when I was a junior with anything GP related or ED related, because I still did a lot of ED. So yeah, it's been so good to actually have done that year. I spoke to when I was in a junior and I did my psych terms. One of my bosses, she's a forensic psychiatrist now, but she had finished her GP training before starting psychiatry training and finishing it. So I'd spoken a lot to her about, you know, what sort of the transition and should I do this, should I not, getting advice from some people who've gone through the process, and she was all for it. So I guess in terms of differences, I think, you know, being a registrar, a hospital registrar, like in GP, is a lot more supported because you've got a whole team. You're often not in a room by yourself, which can sometimes feel a bit isolating because you're seeing patients by yourself. And I guess that's what people see when they, you know, when you do your community terms, you're a bit more solo, flying solo. So I already know sort of how that feels. So that's sort of the big difference. But in terms of other differences, I guess the college itself requirements are there's some overlap, but there's different requirements for the college. Obviously, it's a 5-year program other than a 3-year program. But other than that, it's you know, being a registrar there's a lot of similarities in a lot of ways. You still do a lot of metabolic monitoring. You still, you know, you do make more decisions than you would if you were a junior. But it's just nice to have that support with the consultant if you need them around. Yeah, not to say I didn't have that in GP, but it's a lot more sharing of patients because you share your patients with the boss, all of them. So that's been nice.
Okay. You sort of mentioned a few things there. And I think that there's this sort of common thread that is, it seems like not leadership, but I suppose mentoring and having some sort of role models and people who, you know, seniors who you can rely on, not only clinically in your teams and stuff, but you also spoke about what sounds like a mentor to help you make decisions and get into psychiatry and all that sort of stuff. Was that an informal mentor, or was that as part of some sort of program itself?
No, it was very informal. I'd actually just reached out to her from a previous, my registrar when I was a junior. I'd asked her, do you remember who this consultant was? And she gave me her contact. Or maybe I had it in my phone. So I had just messaged her out of the blue 3 years later saying, hey, you know, I'm in this position. But I do frequent things like, I don't know if you know, creative careers in medicine. That's a big thread. I think there's been heaps of support there from people. There's a GP to psych group that I'm a part of as well. That's been pretty active for people who've gone from GP to psych, because there's so many people who've made that transition. But yeah, even my GP supervisors, who I still say are my mentors, and they still send me various random ECGs that they've seen, or, you know, cases that they've had recently, and tell me a little bit about my patients, how they're going. So they've been really, I think mentors are so important. So they really helped with you know, with applying for this job, and they supported me in that. And yeah, they all, at least I always have someone to ask when I forget some GP things, which definitely comes up. And they're really excellent at that. So that's really good. Yeah.
And it sort of makes me also reflect that, you know, I'm sure a lot of other junior doctors probably didn't have the same experiences or privileges about having mentors and this and that. So we could be missing out. Yeah, so we could be missing out on quite a few really good doctors simply because they just don't have the connections to connect to psychiatry. We have, I think, the Psychiatry Interest Forum, which
yes, I was Should
Was that helpful when you were?
Yeah. So when I was a student, I did write for one of the essays. That's what I remember. And I think PIF was always around at various AMSA conferences as well. So I think it was the Global Health Conference and stuff. There was always like a PIF person there. So my interest was there around that time. And I think there was psychiatry registrars there. So there's always someone to ask.
Yeah,
But
yeah.
I just think the internet just lets you, so it's just been so amazing. You can hear so many people's experiences. There's lots of people who've gone from psych to GP. There's lots of people who've gone the other way. You know, it's so good to hear what people's paths are, because it's almost always non-linear. At least from what I've seen, you know, nobody really always sticks to the same, like, you know, I'm an intern, I decide what specialty and I'm definitely going to do the same thing, and you know, very linearly be able to get through all that. And a lot of people do, but I think for most people it's a bit of a journey, and figuring out what you like and where your life takes you, really. I don't think we really can plan out everything that we need.
No,
Yeah.
well, you know, they say about the best laid plans, I suppose.
Yes.
But it does remind me that it is really important having mentorship throughout our careers, and that it's also important to be a mentor as well, and always be sort of available, and perhaps even, you know, advertise to some extent that, you know, if someone does have the capacity to be a mentor for other people, that, you know, it seems like it's quite worthwhile to do on both sides.
Yeah, for sure. And I think Ava, for our senior registrar, has been really good at matching people for mentorship programs for the stage 1 registrars. So we're all sort of, you know, meeting our mentors and stuff like that. But yeah, even my bosses so far have been really excellent. And you know, this is my first time having an intern, so hopefully I can help them in whatever way I can. I definitely don't feel as senior as I maybe should be, based on just hospital years. I feel like I'm completely starting anew, so I don't know how much I can mentor. But you know, whatever I can offer will hopefully be adequate. But yeah.
Absolutely, absolutely. I'm sure there's a lot that you can offer, and I'm sure there's a lot that anyone can offer in mentorship.
For sure.
It's not necessarily a knowledge-based, you know,
True.
it's kind of about the presence and the interpersonal and a few of these other things too. One thing I was going to sort of pick your brain about is that there has been this philosophy in psychiatry, or this thought that our training starts off in acute inpatient, which is often the really pointy, really difficult in psychiatry. And then it finishes usually in sort of, you know, subspecialty community areas. And the philosophy behind that is that in the really pointy end, you have a lot of supervision and support and big teams and all the rest, whereas you kind of left to your own devices in the community.
Absolutely.
However, I think I also, and a few other people in the previous episodes actually have also said that there's actually a sense of confidence that you build by starting in community first. Like you started in GP first, and you were able to sort of build some confidence around being able to see patients by yourself in a, you know, I guess it's not sort of a psychiatric clinic, it's still a GP clinic. So I was just wondering what your thoughts around it is, given that you know, compared to others who might have just gone hospital, straight to hospital, straight to hospital, but you actually did a community job, not necessarily in psychiatry, but a very sort of autonomous, independent job. And then you went into this, you know, very supported, you know, tertiary center.
Yeah, that's a really good question, because I do think about that a lot. And I think that, you know, as I was going through my year last year, I had spoken to some peers who were sort of in the same level as me. And they were said, oh, you know, before we started, we were told that this was going to be the hardest job that we're ever going to do, because you're in a rural area in a town of 2,000 and you're seeing sick patients by yourself. And there's an expectation to be managing everything. You can't refer. You sort of have to hold on to people as much as possible before you can refer out. And I didn't know that, but I knew it was going to be tough, but I didn't realize really how hard that job can be in specifically in that first year can be.
Mm.
Obviously, once you get good at it and you sort of realize, okay, these are my avenues, then things get a bit easier. But I think that community-based jobs, starting out with them is really rough. But there have been registrars who have started out and have done well in not just GP but psychiatry, community-based jobs. But yeah, I don't know how I'd feel about a stage 1 trainee really jumping in. But again, I don't know what community psychiatry looks like. I know what community GP looks like, and I don't think anything in the hospital, well, not anything, I think some things in the hospital prepare you for GP, but there's so much stuff in GP. It's like, you know, managing menopause, for example. We never had to do that in the emergency department. Like we never, a lot of this stuff that you're sort of thrown into and you say, oh gosh, I have no idea how I'm going to manage any of that. So yeah, I think that I think there's probably a better time is at least after your first term as a registrar. I think if you're the first term registrar and you're doing community term, that could be a bit rough. But if you do maybe the second term, that would be a bit better.
Okay.
Yeah, but it does build confidence. I agree. I think after that year, I said, you know, hopefully nothing, you know, not very many things faze me as much as I would after having done a year of that. Yeah.
Okay. Would you, I mean, and you don't have to answer this if you don't want to, but would you have if you had the choice of not having have done that and just gone straight into psychiatry, you think you would have taken that opportunity, or you think that this was important?
No, actually, no, I think it was really important. I think that I have no regrets at having done that because it just gave me so much confidence. Like, I think having done the year, I just feel that I've grown so much, and it's such a cliche, but, you know, having, you know, managing an arrest by yourself, at least in the first 3 minutes, I never would have been expected to do that. Managing a STEMI by myself, I never did that as a junior. You know, managing very sick kids as being the first person on, never ever did that as a junior, as a junior doctor. So there's so much that I just feel like I've learned to do. You know, I managed, not saying my bosses have always been around when you call them, they're always there, which is such a godsend because you do not want to be the junior doctor managing the major arrest coming in. But you know, having difficult discussions about end of life, like, again, I did all that in GP. I think it gave me the confidence to be able to speak to people and know how to navigate some of those tricky things. I don't regret that at all. I don't think I would have come this way unless I had felt like I had done that year and knowing that that's not what I wanted to do anymore.
I see. Okay, well that's quite insightful in itself, actually, isn't it? Yeah, so it kind of shows that psychiatry is not just a after med school direct path. You know, there is actually there might be a lot of benefits in doing something else before psychiatry. Yeah. How much was the 5-year training and the sometimes it can be really confronting seeing how much you have to do in those, you know, 5 years, you know, 60 months or whatever not of training. How much did that play into or perhaps dissuade you from joining psychiatry?
Well, I guess because I did an undergrad job. Well, I did undergrad med school, so it wasn't as much of a thing. I think that if I was a lot older and if I had kids particularly, I think I would have finished GP training. But there's a lot of people out there who also feel, you know, if I feel the same, that, you know, if I didn't have kids or if I didn't, then I would have done psychiatry or would have done a second career kind of after GP, which a lot of people still do, you know. So yeah, I think that was definitely a consideration, but I think just the virtue of being probably still younger than some of my stage 1 trainees, even though you know, this is my 5th PGY year. Yeah, I just think that I was lucky in that way. Although I still think that postgrad is the way to go. I don't think a high school student knows what they're getting themselves into.
Yeah. It's always that sort of double-edged sword about, you know, the maturity versus too long, I suppose. And in the US, obviously, you know, the med schools are all postgrad, but the specialties are a bit you know, they're a bit shorter and a bit more sort of streamlined.
Mhm.
whereas Australia has a bit of a different system that way. I know that I'm taking up a lot of your time, and I know that you're still working and all the rest, but we had a few last questions, which we ask all of our interviewees. One is that I know you have an interest in sort of, environmental health and social health and sort of global health and psychiatry, but you also seem to have a really strong clinical and, face-to-face kind of coal-face psychiatry approach as well. What would be your three things that you could change either in psychiatry or in the world around you, that you would hope to sort of make a difference if you had some sort of magic wand?
Yeah, well, I think that we could probably regulate our economic system a lot better. I think that would be the number one
Mm.
thing. I think
Mhm.
that would maybe help a lot of the environmental issue. It'd help a lot of the poverty issue. I
Mhm.
think if we just tax people a bit more, that would be the big thing. I think that would make the biggest difference. Um, yeah, that's my number one. I think number two is I really do think that GPs need more support. I think strengthening primary care is the most important thing in preventing mental illness, preventing the tertiary system from getting overloaded, improving access and cost
Mm.
is fixing primary care. And as to how to do that, I'm definitely not the person to ask because, there's a lot of people who are advocating on that front already, including the current AMA president, I think, who's a GP, and various other GPs who do such amazing work in advocating for the profession. I still think it's incredibly important work. I think the GPs who do it do an amazing job, with frankly a lot less fewer resources than the hospital
Mm.
or tertiary centres, or the hospital system in general. So that would be the biggest thing that we can do for everyone's physical and mental health.
Mm. Mm.
And the third thing, yeah, I don't know. I think those would be my two things, if that's all right.
No, that's totally fine. I think it's been this. I imagine it's a bit of an echo chamber, but Medicare being underfunded. I personally am reluctant sometimes to see a GP because I'm like, oh, I don't really want to have to pay, this amount.
Yeah.
And Canberra notoriously has had very few bulk billing GPs altogether. Canberra's an expensive place to live and to operate a GP clinic.
Mhm. Yes.
So I think
Very
we definitely echo the same sentiment. And unfortunately, I think Medicare basically Medicare in a lot of non-interventional specialties is not very well serviced.
mm,
Psychiatry, I suppose, included to some extent as well, although, like you said, we are still far more flexible than our GP colleagues,
mhm,
at least from a time perspective. But yeah, it seems like our funding system is far behind, or our actual
mm,
clinical work, or
mm,
what's required for our communities.
mhm.
The last question I have is, what kind of advice, given your experience in, I suppose, in Singapore, in med school in Australia, going through a bit of an alternative way to get in and eventually into a psychiatry training, what would be your advice either to juniors or to seniors or mentors, about future in psychiatry, or sort of a sort of take home from there?
Yeah, I think the big piece of advice I got given, which I think is just important, which, to be fair, almost everyone that I've seen does, is just the unconditional positive regard and sitting with your patient, and that's sitting with the discomfort of knowing that you can't fix everything, but in this moment that you're there.
Mm.
That's the big thing, which I have seen almost everyone that I've only been here 2 months, so I can't, but most people do their best, and they do try to do that as much as they can, and as much in the constraints.
Yeah.
That's my take home, is the human connection side of things. I think that's been invaluable. The second thing is, yeah, that's tricky because I feel like I'm too junior to give anyone senior than me any too much advice. Yeah,
No, that's
that
all
is.
right. I'm just thinking that actually not doing something and just being able to sit and contain and offer that positive regard, or even just sit with an awful situation is a really active process. you know, I'm a very talkative person, and sometimes it takes me real effort just to keep my mouth shut. And I think so, even like not putting the pen to paper and not doing some sort of active, you know, thing, even though that's your gut reaction, is quite a skill in itself.
And I definitely haven't mastered it. I'm the same. I'm pretty talkative, but it's just like sitting with the silence sometimes is something I've been trying to actively tell myself to do. Because yeah, you can't fix everything, but you can at least, you know, when someone comes through ED and you're sitting there, you know, that all they want is to. I think maybe this is such a cliche, but people just want that having someone is you just want your life to be witnessed, I guess, is just someone to bear witness to your life, and not everyone has someone to just bear witness to, like, to your life. Oftentimes that's what a partner or a very good friend is, and sometimes people don't have that, and sometimes we are the only people who sometimes bear witness to people's life, suffering and tribulation.
I think that especially with the world being more and more isolated, and I think this could even connect a little bit to our professional and our mentorship too, that there can often be professional isolation as well. And sometimes you just need someone to bear witness, you know, to your practice, to your transference, to all these sorts of things.
Oh, yes. And that's why I like that's the good thing about the public system, is that you get a lot of that. Maybe not so much when you're in your rooms in private, or even sometimes in community, although I guess you have got other allied health and clinicians and stuff. But yeah, definitely. I think, like you said, it's so important to have a community. And that's a nice thing about Canberra. It's small enough to have that a little bit. Yeah.
Definitely.
That professional community, so important.
Great. Look, thank you so much, Dr. Salwa, for joining us for our Member of the Season. It was a real pleasure to get to know you, and we wish you all the best for your career. And hopefully Canberra is home.